if you want, you could go ahead and add what school you're coming from, so then we know who all is here with us today. That would be great. And then we'll get started in about a minute. Yay.
Let me see. He had just put him in. Dr. Young, hi. And
all right, so we're gonna go ahead and get started as people are slowly rolling in. So welcome everybody to the Wilderness Emergency Medicine Speaker Series that we're hosting here at the University of Miami. Thank you for joining us tonight. So let's get started. Before we get started, my wonderful co-moderator, Emily, is gonna go over some ground rules with everybody. So Emily, if you could let them know.
Yep. Hi, everyone. My name is Emily Prince-Ravi. I'm a fourth year at the University of Miami, president of the Emergency Medicine Interest Group. Just basic rules, Zoom etiquette stuff. If you can keep your mics muted for the entirety of the lecture, just so we don't have background noise. If you have any questions you'd like us to ask, please put it in the chat box. We're making a collective list, and then at the end of the lecture, we'll be asking the questions, okay? If you have anything else, feel free to message me directly.
Yeah, well, you guys will all have a chance to turn your mics and cameras on at the end and ask all your questions to Dr. Young directly. So just a quick who we are. So my name is Shilpi Ganguly. I'm a second-year medical student at the University of Miami Miller School of Medicine. Basically, why I feel like I have any right to be doing this, I am on our executive board for our Emergency Medicine Student Interest Group. I'm on the executive board for our Wilderness Medicine Society Interest Group. And I'm also on the executive board for Women in Aerospace Medicine, which is a subsection of the National Aerospace Medicine and Resident Organization. I'm extremely passionate about wilderness and emergency medicine, and I am the crazy human that's trying to spearhead this multi-week, multi-speaker wilderness extravaganza. I have an awesome list, a team of people that are down here below. Emily's with us today helping me moderate. So big shout out to my team for helping with the logistics and making everything happen. A quick, why did I go through all this to bring you guys all here? My primary motivation obviously is to expose interested students to the breadth of wilderness and emergency medicine. Wilderness medicine is such a diverse and rapidly evolving field, and I wanted to create an opportunity where students can learn about wilderness medicine well beyond the constraints of the environments in which our medical schools are in. But on a deeper level, whether you're ultimately interested in wilderness and emergency or not, I kind of hope this speaker series is able to showcase the diverse spheres in which physicians can make an impact and kind of inspire others to maybe start thinking abstractly about the way that we could one day utilize our careers in medicine. We've been stuck behind screens and inside walls for so long with this pandemic, but I kind of hope that this series reminds you that there's so much out there and there's so much that we can do as physicians. We aren't confined to the walls of a hospital as a physician. And I kind of hope that you guys think about that as we move forward with our careers in medicine. So like the too long didn't listen to that is like, let's learn some stuff and think big because medicine is cool, friends. A quick what to expect. Today's polar medicine. Last week we had tactical medicine. We have a ton of exciting talks coming up in the future. As you can see, we have a talk every week for the rest of the semester, and then a ton of talks scheduled for into 2021 as well. So, stay tuned, stay involved, and hopefully see you guys at our talks. So with that being said, it is my pleasure to introduce our speaker today. Dr. Young is an esteemed faculty member at the University of Colorado. He attended Boston University for medical school, subsequently completed a residency in emergency medicine at Harvard Affiliated Emergency Medicine Residency, and he did his fellowship in wilderness and environmental medicine at the University of Colorado. He's been a member of high altitude research teams and was the medical team leader after the devastating Nepal earthquakes in 2015. In 2016, he completed a tour as the station physician at the Amundsen Scott South Pole Research Station. He has practiced in many types of austere environments and low-income countries. So please join me with virtual silent claps in welcoming Dr. David Young. Yay. Thank you for coming.
Thank you for having me. What a great intro. I wish I was as cool as you guys were when I was in med school. My God. Yeah, very impressive. This whole series is like super awesome. So I'm privileged to be part of it. Thank you for having me. Yeah, hopefully I can share with you some of my, oh no, hopefully I'm trying to share and it says like host disabled.
Yeah, Shelby, so sorry about that. I'm co-host. You have to share the co-host feature. So we'll do that for you right now and you'll be able to share your screen.
Perfect, thank you. Yeah, just really impressive with everything going on with this whole series. Hopefully you'll learn something from my talk.
We're all super excited and you should be co-host now, so.
Yeah, I think I see it, yeah.
Perfect.
Everyone feel free to put on your videos if you don't mind, just so we can have this as interactive and human as possible. So we'd love to see your faces. Just stay muted or send us a quick chat if you have any questions or comments.
I'm getting like a little quit now. So if something happens, I apologize. Let me see if this works. No. I think that worked, yeah, okay. I'm so sorry, guys. Just 1 minute as
the wonders of Zoom.
Oh, yep. I think this is, I know exactly. Thank you for bearing with me. My apologies.
No, totally understand.
Yeah, are you guys seeing that?
Wonderful. Yes.
Perfect. We can see it. Yay.
Amazing. All right, perfect. Okay, wasn't too painful. Got it up and running. So hoping to talk to you guys about my time in Antarctica, titled Practicing Medicine at the End of the World. Clearly the Earth is round, so ships don't fall off the edge. So I was a member of the U.S. Antarctic program in the summer season of 2016 to 17. Clearly it's the winter up here, but summer down there, which is why it goes through the winter, through the new year. I served as the Amundsen Scott South Pole Research Station physician. For this talk, I just wanted to go through a lot of questions. I feel like every time I would come back to, came back to the United States to talk about my trip, everyone just had a bunch of questions. So I think the best way of going through this is just to like answer a lot of these questions. Like, how did you get a job there? Why do people go there in the first place? Like, how do you even get to the South Pole? Like talk about how dangerous it is, like what the clinic looks like, what cases I saw. And then I do want to talk briefly about a couple cases about winter evacuation. They weren't my cases, but I debriefed the physician who was down there. And so I know a ton about those cases and I think they're pretty interesting. And then little things like how many patients did you see? Like a lot, a little. And then what do you do with your spare time down at the South Pole? Just because it's like light and fun at the end. Cool. Oh God. Getting a beep. How do I? There we go. Okay. So how do you get a job working in Antarctica? Like Shilpi said, I went to BU for med school. I trained at Hammer, which is an emergency medicine residency in Boston. I then went to CU here in Denver, where I'm at now, actually, to do a wilderness medicine fellowship, followed by this gig that I found through University of Texas Medical Branch, who staffs all three of the stations down in Antarctica. Talking quickly about the anatomy of like polar medical operations, because it's very complicated. It's all funded through the NSF, National Science Foundation. They have a subset called the United States Antarctic Program, who really is kind of the main body of that operates all of these like kind of research things that happen down there. The Antarctic Support Contract is the main thing that organizes all of the different organizations that kind of factor into work down there. Leidos is an organization that organizes all of them. One of the subsidiaries of the Antarctic Support Contract is UTMB Health, which is how I got my job. And they have a little division for the Center for Polar Medical Operations. Kind of complicated, but. So the staffing, they hire 3 physicians every summer season, also 3 PAs, 2 nurses, and 2 EMTs. So there's kind of a different array of people who are down in the 3 stations. And just in the winter season, there's just 3 physicians and 2 PAs. Sometimes dentists, pharmacists, radiologists, biomedical technicians, and the chief medical officer also go down and visit there. but like, why? Like, why do people go to the South Pole? It's kind of a random place. It's all about research, right? The NSF is funding all of this. There are 3 American research stations down there, like I had mentioned. So Palmer Station's down out on that peninsula. South Pole is right kind of smack dab in the middle of the continent. And McMurdo, the largest station down there, is located just south of New Zealand. About 3,500, I'm going a little fast, but that's because I have a lot of stuff to talk about. 3,500 Americans are involved in the US Antarctic Program research and logistics. So decent amount of people. 800 of which are scientists. So a lot of scientists go down to basically run projects, and there's a lot more people who just go to support all the efforts down there. The budget is like $350 million annually, which, to be honest, is not enough. We should support NSF more, but it's a lot of money. About 5% of all of NSF spending goes towards the US Antarctic Program. There's about 150 people at the South Pole over the summer when I was there, and about 45 people who are winter overs. They're just about to leave now and transition into like the summer crew from the winter crew. So talking a little bit more about the research that does happen down there, the South Pole Telescope is like one of the largest kind of projects that is happening. They have a number of different projects that are occurring through this one telescope, but it's measuring the cosmic microwave background of space to really detect like the origins of the Big Bang, which is far over my head. These people are super smart and I have no idea what it is. If you guys know what the cosmic microwave background is, like, you're really cool and really nerdy, which also makes you really cool again. So I don't get it. But these are a couple of my friends who are little researchers and amazing from the University of Chicago. I keep trying to click. Another one is Ice Cube. I'm going to turn my volume down just a little bit because I don't know how audio is going to work. But the Ice Cube is this project that it has 1 kilometer square of all of these different sensors that are just dug right into the ice. There's about, it's about 8,000 feet of ice being up below us at the South Pole. And so they just dug into the ice, put all these little sensors that detect neutrinos flying through the air and through the atmosphere for reasons I am too dumb to understand. More research that happens, there's ice coring there. There's a solar telescope, which is like looking at like the solar flares. There's an atmospheric research observatory because it's literally the cleanest air in the entire world. So they're measuring the air there. BICEP and MAPO are both 2 other telescopes. So there's just a lot of different stuff happening down there. There's also tourism. So people also go to the South Pole because they like to visit it. About 44,000 people visit Antarctica, the continent, every year. Shilpi's been. And about 400 people visit the South Pole. Like, the South Pole is really hard to get to. If that number makes, like, it's hard to get to. But people fly in. You can see that little plane down there, and they fly in. It's like, maybe, I think it's $50,000 now, $55,000 to fly into the South Pole. Way more money than I have. Obviously, you have for free if you're working there. Some people drive trucks in, which was like the Toyota thing. And then at the very bottom, you can see that there's some people actually ski in, which is really badass. I'm not cool enough. Oh gosh, stop clicking. So how do people get there? Well, how did I get there, right? So I didn't ski. I lived in Chicago at the time, so I flew all the way over to Christchurch, which is a station for the US Antarctic Program, where there's like a massive hangar, and there's also all these different buildings that we have where we gear up. So we get all this gear, get my little red puffy there, and you can see my bunny boots, into this like basically winterized gear to make sure you don't die down there. Then you jump on a plane through the like passenger terminal down in Christchurch. You jump on a C-17, which is this massive Air Force plane. You can see it's all kind of packed in there. I'm happy because it's like kind of badass. And then you can see on the bottom left, there's like a little airplane that's kind of bringing us down to Antarctica. So from here, we're going from Christchurch down to McMurdo Station. And this is right on the edge, as you can see, of Antarctica in the coast. And again, this is the largest station down there. This is just a quick video of like the cockpit of the C-17 that we were able to fly in. And you can see up in the upper right, that's just kind of a landing ice sheet that we land on. And then you're there at McMurdo. You jump in Ivan the Terabus, which, these are all really nerdy people. So not surprisingly, they name things really like this. And then we get to McMurdo Station. So it's kind of looks like an old like coal mining village. It's very, yeah, looking like that. Not very pretty. And then you jump in this little truck and you take this little tiny plane all the way to the South Pole, which is super sketchy because I think that plane was like built in 1950. And so you jump on this plane, you go through like just miles and miles and miles of this like crazy, just destitute land before you land at the South Pole and go into the South Pole Station. So what is there at the South Pole? Well, there's really like nothing, right? This is actually a picture that I took when I was out for a run. There's like nothing, like it's just like sky and like it blends in with the ground. There's a few things when it's like sunny and you can actually see stuff, like there's actually structures. The biggest thing is definitely the Amundsen-Scott South Pole Research Station. Amundsen and Scott were the two explorers that basically got to the South Pole relatively the same time. Amundsen got there first, sorry, Scott, but the same year. And so they get the stations named after them. It's a huge structure. It's on these like stilts so that the air goes below and doesn't create drifts. You can already see like a drift is already forming, but this is basically where we eat, we sleep. That's my bedroom. There's two long hallways kind of stacked on top of each other where how you get around. It's kind of industrial-ish, not surprisingly. And then of course, there's a bunch of research buildings. We talked a little bit about research. There's a bunch of storage, so berms and arches. You can see in the bottom right, it's like not very organized. There's just kind of shit everywhere. But that's where we store all of our food and different supplies. So like, it's cold down there, yeah, but like how dangerous is it? So arguably the South Pole is like really like maybe the most remote part of the world. Maybe a few other places are kind of similar, but like you can see on the globe, right? Like to get anywhere that anybody actually lives is like a long time. And it's just like large swaths of this ice sheet that no one lives on, and there's literally nothing there. And it's a harsh continent. Everyone always says this little, it's a harsh continent anytime anything goes wrong. So someone drops like a glass or spills like milk or something, they're like, it's a harsh continent. And so we said it often, but it really truly is like, it's really rough. This is one of my friends who was out in this, out working outside or whatever for about an hour and came in looking like that. So still happy about it. It's high, it's about 10,000 feet in elevation. Very dry. You can kind of see there the precipitation is that little thing kind of across the middle, and very cold. I got there in October and it was -60 when I arrived with a wind chill that brought it down to -90. We were outside for about 5 minutes unpacking bags, and I walked in and I like could not feel my face, and it was like very red and not ideal. And it was covered the whole time. So it's pretty cold. Yeah, and it's also, you can see down there, it says humidity 0%. Like it literally has no humidity, super dry. This actually isn't the current conditions at the South Pole. Actually, the sun is coming up a little bit, but I thought I had to look it up today, and I was just like, oh, I don't have a second to change the pictures. So, but it was recently very night-ish like this with the Aurora Australis, which is those green lights there. But it gets very, very dark in the winter. And then Medevac makes it super dangerous, right? Like to get somebody out, Medevac is really, really challenging. So weather, altitude, landing surfaces all make it particularly difficult, obviously very dangerous to anybody who's trying to rescue them. You really can't over the winter. You just can't get there. Planes can't fly in or fly out. We're going to talk about that a little bit later. And there's been several winter evacs just successful at McMurdo, which is like right on the coast, and it's easier to get to from New Zealand, but very few. So really only 3 different evacuations over the winter at McMurdo. The CMO, the Chief Medical Officer at UTMB, is like really the prime medical counsel at NSF to initiate and discuss Medevacs, but it's closely worked with the physicians who are on the ground like myself. It's also very expensive, like nearing $100,000 to even start to initiate an evacuation. So you have to, take that into consideration. It's hard not to. There's also a ton, sorry about the noise, everyone. Hopefully that's all right. But there's also a ton of heavy machines and industrial like workplaces, like this massive generator. And there's also just airplanes like floating around. Like they just come in and come out and you're just like, oh, sweet, that's a massive airplane right there. That's a C-130. There's also a lot of human factors. So this is actually me riding a snowmobile and taking a video at the same time. Don't do what I do. That's not ideal, but I thought it was fun at the time. Someone's throwing wood on a fire, huge open flame. And the lower left, people are skiing behind this snowmobile with a couch strapped to some sleds. You can imagine people are going to get hurt. And then the bottom right are a couple girls who are very intoxicated. Everyone's very intoxicated in this picture, and they're just sitting on some standing on some wooden planks. I don't know how they didn't get injured. So lots of human factors as well can hurt people. All right, we're actually going to get into the medicine soon, I promise. I'm trying to go through this quick because it's like a little bit of just background. So now, what are the medical capabilities that exist down at the South Pole Station? There's actually a lot. So we have a couple cardiac monitors, ventilators, a digital x-ray. We have a dental x-rays and a dental chair. I actually learned how to do dental stuff a little bit before I deployed. We have a couple ultrasounds and a really great video conferencing suite, because if I get into trouble and I need a surgeon or a cardiologist or some other consultation, you can actually, video conference, which is really, really helpful. All from consultants that would be at UTMB. This is the resuscitation room, which is kind of like a little ER room in a way. You can see the gurney there. You can start seeing from the left to the right. You see the ultrasound machine. There's a ventilator. That's a second ultrasound machine, which is, how old is that thing? That thing is I don't know, massive. There's a couple code cart things there with some supplies. The thing right next to it, which looks like it's kind of on wheels, is actually the x-ray machine. And you can see the oxygen tubing coming across the ceiling and down and to bag people using an oxygen tank that's to the far left that you can't quite see out of the picture. We have a lab and a pharmacy, which is great. We have a lot of point of care testing, CBC, CMP, VBG with lactate, D-dimer, trope, point of care glucose. If you're new to medicine, you don't know what these things are, don't worry about it. You can get a pregnancy test, guaiac, HIV test, a strep test, flu test, check some coags. So a decent amount of testing. We can also do ABO blood typing, and there's a system for whole blood collection kit for a walking blood bank. What that means is if obviously we can't have a blood bank down there, we can't purify the blood and separate it into the red blood cells and the platelets and the plasma. There's no way to do that, nor would I have any idea how to do that. But what we can do is we can administer whole blood in case somebody is in emergent need of blood. You just have to do very specific ABO blood typing to do that, and then basically transfuse directly from one person to another, which is a little sketch, but everybody's been tested with HIV and other labs before they go down, Hep C, things like that. There's over about 300 medications stocked. Some of them are running out or small supply or quite expired, but there's a lot of medications that are down there. We also have oxygen and oxygen concentrators. Makes sense when you're about 10,000 feet in elevation. This is our little hospital wing, which is 2 little hospital beds. So if somebody needs to stay longer than just kind of a quick evaluation, we kind of throw them in this bed and let them kind of recover or get antibiotics or fluids or whatever they need. This is my office. This is the first office I ever really had, and it's bigger than my dorm room that I had on the station. Yeah, that's the first time it's ever been cleaned. What type of cases did I see down on the ice? So mostly a lot of kind of primary care stuff, a lot of common cases, a lot of basic cases, like runny nose and a cough, maybe a little bit of nausea. And if it is really infectious, people are fever and diarrhea, that's going to spread like wildfire through the station. So you have to be really careful about making sure that you manage that quickly and prevent it from spreading. Altitude illness was very common. Again, like I mentioned, we're in elevation there. And so people would come right from Christchurch, which is sea level to McMurdo, sea level up to us. And so it was pretty dramatic shock to some people's system. And so, managed altitude illness for usually the first few days that a lot of people came in. Obviously some, mechanical stuff. People are, there's a lot of manual labor jobs that are out down there, fuelies who would fuel the airplanes and deal with heavy equipment. There's a lot of carpenters and plumbers and things like that who just injure themselves with sprains, cuts, things like that. Lastly, insomnia was also really common. So when I was there, it was in the summer, so that the sun never set while I was there. And then also sleep in elevation. And as you guys are learning a little bit more about wilderness medicine, altitude is a very common cause of sleep difficulties. Oh my. So, the things that I saw down there are mostly mitigated by the fact that people have to go through a PQ process to get down to the ice. So everyone's screened for any type of dangerous medical condition that would be precluded from going down there. You don't want somebody who just had a heart attack to like head on down to the South Pole. So they get a full history and exam by their PCP, a bunch of labs that they get before they go. If anybody's over 50, they have to have a stress test before they go down. At all the 3 sites, people have to get a right upper quadrant ultrasound to look for gallstones if they're planning on wintering over. And if you're going to stay at the South Pole because you just can't evacuate them over the winter, they also have to get like ferritin, TSH, a UA, and definitely some psych testing because people are a little crazy if they're going to winter over down there. If you NPQ, which is like non-physically qualify, the participant actually can file a waiver, and then they have to amass this like letters from physicians saying it's okay, gets a big review process from the people deciding who PQs and who doesn't at UTMB. And people kind of go all the time. We had a researcher who was 72 years old who had pretty significant advanced Parkinson's disease. And I was like, when I was there, and I was like him, like really, he's got to come. So he's like walking out in the cold, and I'm just seeing him like stumble around, and I'm just like no, like this isn't okay. He did fine. He didn't need to be evacuated, and he was a really great guy and an excellent researcher. So I'm actually kind of glad he went. So let's go through a few cases that I think would be a little bit more relevant to all of your medical careers and maybe a little bit more engaging rather than hearing just stories from the South Pole. So case 1, we're actually going to do 5 cases, which is why I'm talking fast. We're about a half an hour in. I think we're doing okay. So case 1. So this is a 31-year-old female. She has a history of migraines. She gets some occasional severe menstrual cramps. She was passed out in the bathroom about 2 o'clock in the morning. She was literally dropped off by an unknown person. They knocked on my door. I was like, huh, as I'm sleeping. And they're like, someone's in the clinic. And then I go out and be like, who's in the clinic? And that person literally disappeared. I'm like, what the, okay, great. So I walk into the clinic. She's literally on the ground in the clinic being writhing in pain, grabbing her belly. I'm like, you've got to be kidding me. Like this. So she awakens enough to basically tell me that she's drank a lot of alcohol, 4 drinks, I mean, decent amount, and just had severe diffuse abdominal pain, so that she had syncopized in the bathroom. It was also vomiting in the bathroom and had a bunch of diarrhea. Also, her period just started. So I got some vital signs. So her heart rate was fast and her blood pressure was pretty low, 82/62. She's sitting a little low, but again, we're at 10,000 feet. So that's about not terribly far off. Her exam, she's ANO times 3, so she's with it, but she's somnolent. Obviously, like I said, she's quite tacky. Lungs and heart are lungs are normal. Her heart obviously is tacky. And then she's diffusely tender, like really firm, guarding, I can't push anywhere. She's just writhing in pain, really, really tender. So I'll turn it over to you guys. What is on your differential at this time? Out of the studies that you have access to, what do you want to get? And what treatment do you want to start? I don't know if if anybody really wants to answer her, or we can just kind of maybe think about these things for a second. I'm guessing the latter. So we'll just keep moving.
Can write in the chat box and I can speak for you.
Oh yeah, Emily, I love that idea. Oh wait, let me go backward. How do I go backwards? Don't look. That's not gonna work.
Cover your eyes, guys, or we'll do it for the cases next.
All right, yeah, this is our practice case. This is practice case.
Yeah.
So get ready.
You guys were all right. Weird. So after about a liter of fluids, her blood pressure got a little bit. So I had to start an IV, collected all these labs, and doing all these things myself, which I'm basically incompetent of doing because nurses do it for me. But her blood pressure is 106/76. So a little bit better. Heart rate's getting a little better. Her labs are pending because they take a little while through this machine. And I'm not able to get any urine from her. I'm like, you have got to pee for me. Please, 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 you have got to pee for me. I need a urine sample, mainly because I need to do a pregnancy test. And she's just writhing in pain, just looks really, really uncomfortable. So I'm like, I'm going to try, we don't really have many opioids, but I was like, all right, I'm going to try a little bit of morphine for you. And I totally tanked her pressure to 72/56. And she's just pale, diaphoretic, writhing in pain. It didn't even touch her pain, right? She's just sitting there still writhing, and I just tanked her pressure. I do a FAST, of course. So a FAST is an ultrasound of her abdomen used in trauma, but you can see free fluid in the abdomen. Clearly, I'm very concerned about a ruptured ectopic pregnancy. Maybe that's not so clear, and if it's not, that's fine. But I am very worried about that. So I really want to get an HCG, and I try to use, if she can't pee, and I can't get urine from her. So I take the blood and I try to like drop it into like the little, pregnancy test. And it like just like coagulates and coagulates. And so I like try to dilute it, and I have to dilute it like 4 different times. And then it works and it's not pregnant, but I'm like, did I dilute it too much? Like, I don't like, so I don't know. So it was negative, but take it for what it's worth. I gave her, of course, another liter fluid bolus because of her blood pressure. I do a guaiac test on her. I don't actually put my finger in her butt. I just asked her to give me a stool sample, which she was able to do, which was nice. She was having diarrhea earlier. And then once I saw she was guaiac positive, which means there's blood in the stool, I give her some pantoprazole. It's a PPI that helps reduce the acid in the stomach. Labs returned with a white blood cell count of 16.4, which is elevated, but everything else is pretty normal in her labs. Slowly, so I actually start a little bit of a fentanyl drip, which was a little jerry-rigged, but that helps. It doesn't lower the blood pressure nearly as much. Probably should have given that originally. And her blood pressure is kind of slowly improves. I give her some more fluids. We kind of watch her. Her pain gets improved. Eventually, after about 12 hours, she's like, I feel much better. Initially, I thought literally she was going to die because I thought she had a ruptured ectopic. And what do you do with that when someone's at the South Pole and has like 5 days to get medically evacuated? But she ended up doing okay. I think she probably just had like really horrible gastritis and maybe a gastric ulcer. I told her to follow up. She got evacuated like after like a week or so. She wasn't like an emergent one. She just kind of went out a little bit later. I never really followed up. But she never really followed up with me. I told her to like, email me her results of everything, but okay. I'm doing okay still. Case 2, you guys ready? So this is a 38-year-old gentleman. He has a history of diabetes and obesity. His BMI is 48. That does not preclude somebody from going to the South Pole. He presented 1 hour after arriving to the South Pole. So he just literally flew in, and he was just like kind of walking around, and everyone's like, you okay? And he comes up to the clinic saying, people sent me up here. I've just been having some shortness of breath and some chest pain. Never had it before. It's mostly on the left side. It's kind of wrapping around to the back. He reports nausea, diaphoresis, sweatiness, and a mild dry cough. Didn't have any fevers, didn't have any myalgias. His vital signs were a little concerning. So he did have a heart rate of 112 and a respiratory rate of 28. The rest of them are pretty normal. He was tacky, like I mentioned, had an increased work of breathing. Like he really looked like he was short of breath. His lungs were actually pretty clear. Again, his BMI is 48, so it's a bit hard to appreciate them. Chest was really non-tender. I couldn't reproduce any of the tenderness that he was having. Belly was normal, and I didn't appreciate any leg swelling. So now we get another chance. Round 2. What's on your differential? Like what studies do you want, and what treatment do you start?
Oh, you guys are so great. Okay, so we have some participation here. On our differential, we have a PE, acute altitude sickness, acute associated hypoxia, and then ACS, altitude sickness.
Awesome. Yeah, great. I think, initially for me, I was very concerned about a PE, like tachycardia and somebody who's a bit overweight and has been on a plane for like, it takes forever to get from Christchurch. It takes, again, another flight here. So I was definitely worried about a PE in this guy. But, 38 years old, like, you don't typically expect ACS, but, he's 38 and he's obese and, has a bit of a medical history. So possible for sure. Oops. So here's his course. So I got an EKG on him pretty quickly. He was sinus tach at 104. He had a Q wave in 3, but didn't have like S1, Q3, T3. It's a sign of PE on an EKG. Otherwise normal. Definitely didn't have like a big old like tombstone-y crazy STEMI going on. I got a chest x-ray, but honestly, like it was so hard. This is a big dude. And it was just so hard to get the penetration of the x-rays right through his body. And I'm not an excellent, rads tech. So it just was really, really challenging. And he also had a really hard time taking a big deep breath because his pain was quite pleuritic. I did get an ultrasound of his chest. He had normal lung sliding. So there wasn't like a pneumothorax or anything that I could see. He didn't have a pericardial effusion, and his heart was contracting normally, so it didn't look like he was like took down a wall of his heart in any way. His lung parenchyma, I really wanted to see like what his lungs looked like, but again, he's a big guy, and I had a really hard time seeing the windows with some pretty crappy ultrasounds, to be honest. He had a trope and D-dimer, which were negative, thank God, because either of those being positive would be really concerning, which all of a sudden made ACS and a PE much less likely. The D-dimer had expired about a year ago, so I kind of believed the D-dimer test, but I was like, really? Like, there's not an actual real D-dimer test here? Turns out he didn't have a PE, so I think it was right. He did have a white blood cell count of 14, but the rest of his labs were pretty good. About 2 hours later, he he's just staying in the clinic. I put him in one of those like little hospital beds, gave him actually some oxygen because he was just so short of breath. Like, it kind of made him feel a little better, even though his oxygen saturation was okay. He became so fatigued and like very lethargic appearing. Like, he was breathing really fast, and he was just like so fatigued. I like had to like sternal rub him to wake him up, and he'd be like, huh? Like, what's wrong? And he just would like kind of like fall back asleep. Like, not a good mental status. If you're declining that rapidly at the South Pole, it's like no good. He continues to complain of severe pain. Like, I can't give him any pain medicine because he's like so like out of it. Like, what do you do? So I put him on a non-rebreather, and I'm like, this guy's got to get out of here. Fortunately, we were able to get him out pretty quickly. There was a second plane coming in for the day that I was able to actually get him back out. It was like 4-hour window that I actually treated him as his physician. And in that time, I was actually able to evacuate him back to McMurdo, which is like unheard of because it really never happens. He was evacuated to Christchurch from there, and he was found to have bilateral pneumonias. Not sure why, but had bilateral pneumonia and required a 7-day hospitalization. So he was pretty sick. Was in their ICU for a few days, and then discharged and did fine. He actually went back to the ice after he cleared up, but he didn't come to the South Pole. He just stayed at McMurdo. Case 3, we're just tearing through these. So this is a case 3 of a 25-year-old gentleman. He had a history of cardiac surgery at age 4 in India, of all places. And then he presents after a snowmobile accident when about a day after he had arrived. He was basically training on the snowmobile and like literally just like went kind of nuts and just crashed into like basically a huge like one of those like big crane things, like the wheel of it. He broke the windshield. He says that he kind of hit his knee and his chest over like while doing this, and as well as his forehead. He thinks he was about 20 miles an hour. He was wearing a helmet. He didn't lose consciousness. When kind of asked further about like, were you having palpitations, or like, were you like, why did you crash? He was like, I was just feeling really lightheaded at the time. Like, I've never really driven one before. I don't know if that has anything to do with it. Okay. His vital signs. So we defer to temperature because it's kind of trauma. I don't really care. His heart rate was 134, not ideal, good, but a good blood pressure, respiratory rate, and sat. He is tachy, like I mentioned. Chests were clear. He did have some chest wall tenderness over the sternum itself, but I didn't really see any bruising or like abrasions or anything. He did have like, I think he had a little something over the forehead, but it was so minimal. I think I just said that there was nothing. His C-spine was non-tender. His right knee had quite an abrasion, like it wasn't like in the picture in the upper right. And he really wasn't able to bear any weight on that because of significant pain to the knee. So here we go. Like, what's on your differential? What studies do you want? What treatment do you want to start? Same questions.
Awesome. Colin was kind of already writing what I was thinking. He's thinking maybe an arrhythmia that led to some lightheadedness and then resulted in his crash. He'd like to get an ECG. Anything else, you guys, on your differential or treatment? I think that's kind of, considering his age and how he presented and how he described it, that would be the first thing on a lot of our minds.
Love it. Yeah. Maybe a knee x-ray. Yeah,
for sure.
Not broke. Yeah. So I start with a knee x-ray. So you guys are all smarter than me, but I did not get an EKG initially because I'm like, oh, he just was like little lightheaded. Whatever, like, let's check out this knee. He just like crashed a motorcycle. It's like totally all trauma. So you guys should have been there and not me. He got a chest x-ray as well, just because he was having some sternal tenderness, and I just wanted to make sure his lungs looked okay. I gave him a little Tylenol initially. He's like still in some pain, so I ended up giving him a little oxycodone too. just to help his dizziness, and then discharged him from the clinic just to like kind of rest in his kind of dorm room. I just told him to come back the next day and just let me know how he was feeling. And he still said he felt pretty lightheaded and a bit short of breath. And the chest really hasn't felt any better since the accident. He was able to kind of hobble around. He was able to bear some weight after a little bit of pain medicine on his knee. I check him out. His heart rate's still pretty quick, like 124. So anything else in your differential? And you guys all wanted an EKG because you guys are brilliant people.
We have someone considering obviously blunt heart trauma and tamponade also.
Oh yeah. Love it. Absolutely.
Some,
right.
pneumos, depending on how he landed. We're not really sure, but the short of breath, you kind of want to check all of that out. Great job.
I went too fast. My apologies. Yeah, absolutely. I think like a cardiac tamponade is really smart. I didn't ultrasound him, and it could have kind of like bloomed, especially because he had prior surgery and maybe is like got a blood vessel that's a little bit more like delicate or a little more likely to be a little friable in his mediastinum or near his heart. Definitely pneumothorax. Like I did get that chest x-ray initially. I didn't see a pneumothorax, but could he have had a small one and it's just progressively gotten worse? Absolutely. I did get an EKG on him, which showed sinus tach because he's been quite tachycardic since, but with a pretty significant right heart strain pattern, which was a very bizarre appearing. And it was very different from prior EKGs because in the PQ process, if you remember, to get down on the ice, you have to go through this PQ process. And I like pulled up his prior and it was like, his prior was totally normal. Despite having this like massive like incision on his chest, I was like, oh, he's got a perfectly normal EKG. So I checked some labs on him, including a troponin, totally normal. And I don't know what to think of this. I basically notify my CMO, let him know what's happening. And we're both like, well, let's just, let's watch him a little bit. Let's see how he does, but we'll probably have to evacuate him with this tachycardia and these like EKG changes. We're going to work on getting him out, but we probably don't need to get him out today or like work on getting him out as soon as possible. We'll wait for another plane to come in. Of course, I've checked on him a couple times throughout the night, doing fine. He comes back the next day, still tachycardic. And now he walked up the stairs to the clinic and he's just like visibly short of breath. Repeat chest x-ray shows like mild pulmonary edema throughout both lung fields. His satting only 91% on room air, so not ideal. I threw him on a little bit of oxygen just because he looked like he was just really working to breathe. And obviously he has this new pulmonary edema, and repeated the EKG after a little while on the oxygen, and it totally resolved the strain pattern. And I was like, what is happening? So talk about this with a cardiologist. They recommended starting him on some Lasix and a PDE5 inhibitor, and planned on evacuating him, right? And so we keep him on oxygen until he gets evacuated. I can't go backwards, but so that's largely the case. I asked him, he actually lived in Chicago too. I was like, you've got to get an echo. You've got to let me know what's going on. You've got to see a cardiologist. He didn't really know any of the details of the surgery that he had, but was told that everything had been kind of resolved from his cardiac surgery as a child. My suspicion is that he just always had elevated right heart pressures, and that the elevation itself increased those right heart pressures to create a right heart strain, and eventually a backup of fluid to create some pulmonary edema. Not totally certain why, but I'm very curious to actually have some information, but sadly I don't have it. But there's just another case. It's kind of interesting. So now we get to talk about like an actual winter evacuation, which were not my cases, but it's kind of fun to talk about. How are we doing on time? Oh yeah, we're gonna fly through this, maybe like in 6 minutes. Okay. All right. This wasn't my cases anyway. So case 4. So this is a 58-year-old gentleman. He has a history of hyperlipidemia, ran out of all of his meds. He uses tobacco, and he presented with shortness of breath and substernal chest pain while walking upstairs. No good. Pain radiates to his left arm. He's got 5 out of 10 pain. Medical staff gets him from the carpentry area and bring him back to the medical clinic because he was like too sick to even like get up the stairs. His vital signs are, they're okay. He's a little hypoxic. He's hypoxic at 84. Exam was pretty reassuring. They give him a couple liters of oxygen with his SAT increasing. They give him some nitroglycerin, some aspirin. He's now pain-free, but he has an EKG that looks like this. Kind of poor baseline, but doesn't look so good. I would ask you what you think it is, but you guys probably already know. This is a follow-up one. No good. This is a total inferior STEMI. So no good, right? He's just totally, like, it's just STEMI in the middle of the winter in the South Pole. CMO's notified, they have an emergency cardiology consult. They decide that he actually should get lysed. So they give him tenecteplase, which is like an old lysis unit agent. His troponin peaks at greater than 50. It's like above whatever the cartridges can even detect. And he ends up having some arrhythmias as they keep him in the hospital, in the little hospital bed, with some wide complex tachycardia after the tenecteplase, likely because of a reperfusion arrhythmia. What does that say? Reperfusion arrhythmia. Oh God. So he gets an EKG the next day. You can see he's kind of queuing out. He's got some T-wave inversions in his inferior leads, 2, 3, and F. Well, yeah, a bit of 2, which is pretty classic. That same day, he ends up being, pain-free, classic post-MI findings. At this time, they talk about evacuation, like maybe we could try to, but they think it's too dangerous, so they just want to medically manage this guy. Minimum time to be to even be evacuated is like 2 weeks. So after 2 weeks, if he's still alive, then he's probably just going to do okay. The problem, though, is that the station opening is not until another 150 days away, where we can't even get a flight in for another 150 days. And the medications, you don't have to look through all of that, but basically there's not enough medications to medically manage him. There wasn't enough metoprolol, wasn't enough statins to make sure that he would last through the thing. So they thought, what if we just airdrop these meds? Because you can fly a plane over, you just can't land it. So they thought an airdrop would be planned if they'd supply him from McMurdo and then just fly over. But by 6.5, he's actually persistently hypoxic. They do an echo, and he's got some pretty significant right ventricular dilation, right? He probably just totally blew out that wall, enough dead muscle in the heart there. He started on Lasix and sildenafil. Sildenafil was considered if he got worse. A couple of days later, he's actually doing okay. He started kind of walking without much difficulty, he's breathing okay. And so evacuation was totally removed from the discussion until case number 5. Oh, damn, doesn't get any better. So 46-year-old female, she's got a history of a cholecystectomy back in 2015. She actually did it to physically qualify for a winter over, which she had a gallbladder, so you have to get your gallbladder taken out just to winter over, which is kind of crazy. She also is hypothyroid on Synthroid, coming in with cramping, abdominal pain, and vomiting. She had no stool or gas for the past 24 hours. Vital signs are actually pretty unremarkable there. She had a distended, minimally tender abdomen with decreased bowel sounds. You can see where this is going. She had a rigid sigmoidoscopy. The doctor, I don't really know how to do those, but the doctor, who was a Kiwi critical care doctor at the time, who was down there for the winter over, he's like, oh yeah, I do rigid sigs all the time. So he looks inside, empty rectum, there's no stool, no gas, and pretty normal mucosa. So there's just nothing there, nothing's getting through. They get an X-ray, which shows a pretty sizable large bowel obstruction with, I don't know why they measured it in inches, but it's a little weird, but especially for a Kiwi. But this is actually her image, but 7.5 centimeters is pretty dilated. And so she totally has a bowel obstruction, not ideal. They try to medically manage her, place an NG tube, give her bowel rest, try to suck as much out as you can. They consult surgery, obviously the UTMB surgeons. They recommended a CT scan and a transfer. Think surgery, not able to do either of those. They also consulted endocrine for possible maybe hypothyroids, working on trying to maybe she's a little too hypothyroid and they're kind of slowing down her system too much, but didn't contribute to her symptoms at all. They have to give her some opioids to control her pain. They start her on some antibiotics, I'm not sure why, and give her a little bit of steroids in case she's got some sort of rheumatologic process that could be causing some inflammatory bowel disease. A few days later, she just didn't do any better overnight, and still distended, had no bowel movements, no flatus. They're not really able to pull anything out from the NG tube, likely because of an ileus, maybe constipation, but really probably not. Likely there's a pathologic process, either completely kinked, a tumor, maybe an inflammatory bowel disease that's actually really blocking, but whatever it is, it's probably a pretty significantly pathologic process. The next day, they try a little bit of oral fluids, but she just has terrible pain. She cannot tolerate anything orally. And they don't have any they don't have D5 down there. So there's nothing to give parenterally, even any calories. Like you can't get anything in this woman, right? Any calories, any type of, obviously TPN is like out of the question. We don't have that. They repeat the KUB. She's just got worsening dilation. So they just returned back to complete bowel rest. And then, maybe we're going to try a virtually guided loop colostomy if the patient worsens further. This is like an internal medicine doctor doing like a loop colostomy, like not ideal. A surgeon from Texas would be kind of guiding this like New Zealand doctor on how to do this. It's like my worst nightmare is trying to like cut into somebody's abdomen, not knowing what the hell I'm doing, trying to save somebody's life. But that was considered. We don't know why the bowel obstruction is happening, but like probably a pretty dangerous process because we're unable to feed her and there's no parenteral nutrition options. They actually were able to authorize a Medevac, and NSF approved it. So they were going to try to go through South America. The questions are, do we evacuate through South America versus New Zealand? Oh, I got to go a little faster. There's aircraft pressurization issues. Like, are you going to just blow her colon when you go higher up in the air? Obviously, in-flight patient management, like if you don't have to have a medical provider in the actual airplane, you shouldn't, because there's a good chance that you're risking the patient's life, or sorry, the rescuer's life by sending them down there. So the less people, the better. But do you need to have one? Should you remove one, or should you move the actual guy with the MI who's like who's doing okay, but not great? All these things. Ultimately what happens, I'll just kind of skip through this, but Ken Boric Air, which is a Canadian company, is hired. They fly on down all through North and South America, all the way down. Here's them landing in the middle of the night, land successfully. They keep the motor, they have to keep the engines running. They load this patient in this airplane. Actually, it looks like the engines are stopped there. So I heard that they stayed, but maybe they turned them off for a second to just load the patient. And then we're able to get these patients back to South America. They took both patients, and they both are doing fine. They won the Smithsonian Air and Space Museum trophy. Yay, Ken Boric Air. Yay, rescues. Neither condition could have been detected in the PQ process. This guy was not the healthiest. She had cholecystectomy. It's hard to really, NPQ these people. You could consider lowering the threshold for obtaining stress tests on the winter over employees. But definitely they learned that people need to have enough of their own medications and maybe excess medications down there, to make sure that, you stock up for unforeseen emergencies. So let's go back to the summer. How many patients did I end up seeing? Really not that many. I did have a PA down there for most of the time. We saw about over 200 patients. So that's about 2 patients per day on average. So life was like way easier than the normal ED. But I did have to do a lot of things like keeping the clinic organized and stocks up to date, and a lot of communications back to the United States. It took a lot of our time. We did a lot of emergency response team training. So there's a crew of 12 of us who would respond to any type of emergencies. We did some drills. We made sure all the stocks were, ready to go. So we did those things, but I did have a lot of extra time. So what did I do? We did some a lot of board games. This is also making cookies and doing screen printing, t-shirt, whatever, screen printing stuff. I worked out a lot. We did yoga, we climbed. I'm trying to do pull-ups. We did lots of volleyball, which I'd never really played before, but it was super fun. They had a little gym there, which was just big enough for a volleyball thing. This is called pole runs. And so you go in the sauna, and then you run outside to the South Pole. It gets really cold, and then you have to run back. We actually did some real running instead of just pole runnings. We actually, I coordinated a marathon down there, which was really fun, very cold. This is all of us in the upper right, starting off on a run. We had some parties. People drank a lot of alcohol, which I didn't really love because I'm the safety captain, but it's also, you have to have a little bit of fun. And then, will I ever go back? Yeah, I sure hope so. This is me. I'm really happy there. It was honestly one of the best experiences of my life. Is really, really unique. It's just really hard to work in academics like I am right now, and take 5 months off in the middle of your career. So questions. Now we have time. How did I do? Oh yeah, a little tight. Sorry about that, guys.
No,
You did
you were
great.
great. You were awesome. I just wanted to say really quick, so we have time for questions, just to thank you for your talk. That was awesome. So I'm gonna hand it over to Emily so she can curate our Q&A. But I helped with the Medevac out of Eduardo Frei, so I can empathize. I can't even the winter evac, just crazy to me. But so yeah, Emily, take it away with the Q&A.
Yeah, Dr. Young, this was amazing. Thank you so much.
My pleasure.
What I liked about your presentation in particular is how much detail you put into getting there and all of the background logistics that we never are told until we're put in this situation or, are looking to apply for something like this. So that was very, very cool. So guys, if you have a question that you'd like to ask yourself and unmute yourself, please raise your hand and we'll call on you. Otherwise, I'm going to start with some of the questions you guys have already submitted, okay? So you can hear me okay, right, Dr. Young?
I can, yeah.
Okay, great. So first question, how would someone become a practicing physician here at the South Pole? How do you get started and how do you find this position?
Yeah, good question. It is, it's a little random. It's one of those jobs that I had heard about when I started my wilderness medicine training. So again, I did an emergency medicine residency, then I did an extra year in wilderness medicine to do a wilderness medicine fellowship. And I heard about it through my fellowship and I was like, I would love to go to Antarctica. I'd love to expedition medicine is totally up my alley. I had done a number of different expeditions before. And so I kind of gained a bit of a CV that would make me pretty qualified to go down there. Sometimes they get desperate and they hire Kiwis who are critical care doctors. He was awesome. His name was Hamish and he's super awesome guy, but maybe not the most appropriate person for somebody internal medicine trained. They'll sometimes send down general surgeons as well, but typically they're looking for people who are emergency medicine and have some experience in the wilderness. And I think more and more as you go along, it's really hard because, what specialty manages trauma, which, I had a case of trauma, which, we also have to, manage medical things. And so there's just not a lot of specialties that'll blend all of them other than emergency medicine. But I'm biased because I'm an ER doc. So I basically heard about the job. I applied through UTMB and then had an interview. They liked me enough to actually send me to the end of the world.
So that kind of blends into Jonathan's next question about what kind of physicians normally go there. Obviously, EM is a great specialty because you're, what is it? Jack of all trades, master of none kind of thing. So are they generally all EM physicians? Is there a trauma surgeon also available? I forgot how many positions were available per trip, if you can just remind us, and what other physicians were there with you?
Absolutely. So no other physicians. I was the only one. For most of the time, I had a PA who was there as well. He was mostly internal medicine trained, so he wasn't. Haven't done a lot of emergency training, but kind of assisted me with some stuff. But I pretty much saw almost all the patients, unless they were very, very minor. And then when you winter over, you really just have one physician there over the winter. The other base is actually the McMurdo, because it's bigger, has 2 physicians and a PA and a nurse. And then there's just a physician at Palmer. Palmer's the smallest station. So it's not that many. And then when you winter over at Palmer, you just get one physician again. And then there's just one physician at McMurdo when you winter over. And I think they have a PA as well over winter. So almost everyone these days is emergency medicine trained. In the past, they had sent surgeons. They actually sent an orthopedic surgeon at one point in time. I honestly think that's a little suspect, only because orthopedic surgeons are incredibly talented. They're very well trained, but I would worry about them managing a medical case. And so, obviously you can consult other services and you can work, in terms of other services, and anybody who's been through medical school, right? A lot of stuff. But that makes me, a little worried. So I think pretty much these days, I think it's really just EM.
Mm-hmm. And that also blends into another question people had. As a combo I put here, a combination from Haley, Shilpi, and Ryan. So they're asking how often on call you are on, but that's pretty much 24/7, 365 at this point. Yep. Do you have any? I
allowed myself 2 beers at any one point in time, which maybe is a little bit sketch, but I also was just I like beer, so.
So, and then as far as any techs or nurses, you basically performed all of the collections, all of the it seems like all of the ultrasounds and the radiography as well. Yeah. So from top to bottom, that was all you.
One-man show. Had a PhD, but yeah.
And then one other thing I thought was interesting on top, blends into this question: how often medical supplies came in, and how how frequently would you go over inventory and be able to request certain things?
Yeah, we didn't really run through inventory, like actually run through supplies too frequently, because we only saw a couple of patients a day, but we made sure that we had enough stuff. There was actually a storage room down, down below that actually had, it was like just a medical kind of like big storage closet. So there was like tons of gauze and like sterile gloves and like whatever you can imagine. We had to we only inventoried that once, but it took 2 weeks to inventory everything. We just counted something like one thing of like everything. And this clinic has been around for, the building I think was built in 2011, so it had been around for like 6 years-ish or 5 years-ish. So they had medical supplies before, so a lot of this stuff is really old down there, and so sometimes we would throw stuff away, but if it could potentially work, kind of didn't have to throw away because it was just basically get buried in the ice as trash. And it's like, well, you can either bury it in the ice as trash, or you can just keep it. So we did throw away some stuff just for organization's sake, but most of the time we just kept stuff. We had a couple shipments of extra supplies, mostly medications that we were a little bit worried about. We had to count every single pill that was there. Every time like that you get a new crew, you have to do all of that. What it did take a long time to do all this inventory stuff, but I literally wasn't doing anything else, so it wasn't too bad.
Awesome. And then one more question. I'll kind of combine several thoughts, if you don't mind, in one running question. So we have, so are families able to come with you? And in general, if you have a family, how is this expedition? And are you able to communicate with them? How long are you away from them? And how just in general is it like to be separated from your world and staying in communication with the world that you came from?
Yeah, that's a good question. Are you asking if I'm single? Is that the question?
Maybe someone else is. They might be asking.
Kidding. But no, I didn't have a partner at the time, which made it a little bit easier to travel that far away, because family are not allowed. No kids, no spouses. Sometimes people do travel with their family there, but that family member has to have a role. So they have to be a scientist. They just happen to be a scientist and a physician, or they just happen to be, there has to be some sort of connection to bringing that person there. It costs a lot of money to bring each individual person that far onto the ice. I don't really know what the estimate was. I think people were saying it was about $12,000 a head to get them there. And then to keep them there, it costs like a decent amount of money just for upkeep, just to like live there. It's like kind of expensive, because transporting food there, like, the whole station ran on jet fuel. And so we're constantly, which is sad, there's a plume of smoke. I said that the air was like perfectly clear, but there's a plume of smoke that's always going in one direction. The atmospheric research station is upstream. So it is measuring clean air, but like it's just burning these fossil fuels, which costs a ton of money to even get there. I was kind of shocked at how not green the station was. There's no like solar, there's no wind.
Yeah, you would expect it to be completely like futuristic, Icelandic style, like completely self-sustainable.
Absolutely, you would totally think so, and sadly it's not, because I think it's honestly the cheapest way of keeping that station running. So I went on a total rabbit hole there. It is really hard to be away. I was there for quite some time, so it's a little challenging to like miss, and there's no dirt, there's no trees, there's literally nothing alive down there. So that's kind of weird. And I just missed trees, or just like humidity in the air, or just like smelling nature. It just was really odd, but it was such a unique experience. Like I was willing to trade kind of, everyday life for this kind of weird otherworldly experience. And I have family members, no immediate family members, I guess. I don't have kids or anything. So, it was easier for me to travel and to do this project. But of course, I missed my friends and, my family back home. And, you could kind of be in contact with them. It's a little bit challenging, but, we had to steal internet from the ISS, International Space Station, when we were there. So we only had about like an hour and a half of internet per day. So I would try to, call my family and be like, hey, what's up? I did have a sat phone access, which I often used to call my family, even though I probably wasn't supposed to. But so I'd call my family, and the 2016 election happened while I was there, which, I was on the phone constantly just trying to get updates, and a little bit in disbelief still. But yeah, so it's a little bit of a weird place. I don't mean to take anybody's time. I'm happy to answer any additional questions if you guys have them. I do realize I ran over time. I apologize.
No, yeah. Yeah, we're a little bit over. So I know there's like other people have meetings and stuff. So if you have to leave, that's totally fine. Thank you so much for giving your talk, Dr. Young. That was truly amazing. Dr. Young has been kind enough to say that if you guys have any questions that we weren't able to answer today, we can send them to him and he's happy to answer them. So feel free, if you weren't able to put it in the chat, email them to me and I can get them to him so you can get your answers. But just want to make sure everybody can get to their meetings, and I don't want to keep you here too long, Dr. Young. You were so gracious with your time, and that was truly an amazing talk, and I know it benefited a lot of us. So thank you so much.
You're more than welcome. Thank you. Thanks for having me.
Absolutely. And I hope you have,
Thank you, Dr.
everybody has a great day of your day. Thank you everybody for coming. I really appreciate it. I hope I see you guys at my next talks, and yay, let's keep exploring.
Yay.
All right.
Bye, guys.
Bye, everybody.